Good afternoon, everyone. My name is Colyn Watkins, and I'm one of the orthopedic surgeons at Boston Children's Hospital. I specialize in neuromuscular conditions, and I'm part of our acute flaccid myelitis program at Boston Children's Hospital. My main focus is both non-operative and operative treatment of hip, knee, and ankle conditions in children and young adults with neuromuscular conditions. Today, I'm going to be speaking about lower extremity contractures, hip subluxation, and limb length inequality in AFM. Okay, so the plan for today is to discuss an overview of the issues in AFM and then explore the specific topics of foot and ankle contracture, knee contractures, hips, and then finally limb length difference. Now, we know that AFM is a neurologic condition that affects the spinal cord, and it's an uncommon disease, and it really is a fairly recent disease. So I think the first thing I have to say is that the data out there on the orthopedic treatment for AFM is sparse, and much of it is small case reports. For me personally, while I have an opportunity to see a number of families affected by AFM, it's still a very small absolute number. And so much of my experience, and I suppose my general outlook on the treatment for this, is shaped from my practice treating the still rare, but more common than AFM conditions like transverse myelitis, spina bifida, spinal muscle atrophy, and spinal cord injury. Now, obviously, these disease entities are different than AFM, but their common phenotype of a neurologic loss and subsequent orthopedic manifestations tend to share some common pathways. So, in general, I think that when you're treating patients with neurologic deficits and loss of motor function in particular, it's important to talk broadly about both non-operative treatment like bracing and the concept of independent mobility. Each patient affected by AFM or any neurologic disorder for that matter tends to have their own unique deficit, and it really does need to be individualized. That being said, the overall goal in my mind is to provide the patient with the greatest amount of independence. And I think it's important to note that when treating patients with AFM, I focus on independence and not necessarily just ambulation. Now, some patients will do great with just a small brace and they gain significant independence to do the activities they enjoy. Others need crutches or a walker, and yet others are truly most independent in some form of wheeled mobility, like the wheelchair you see here. The bottom line is that every kid deserves to explore and enjoy the world around them, and it's our job to make it easiest for them. Okay, so let's get a little bit more specific and discuss some of the foot and ankle issues in AFM. So first of all, let's just talk about bracing, which I think can be a simple yet fairly effective form of treatment for any child with a neurologic deficit. So I've got two braces here, and the point that I want to make is that they look similar, but they have an important difference. So notice the hinge on the AFO on the left. Now, as I've said before, every kid is different, but I find that ambulant children with a more affected distal extremity neurologic deficit will tend to fall into a crouch or a knee bent gait with a hinged type ankle foot orthosis. My preference instead is a more solid type AFO, like the one that you see here, that supports the weak ankle plantar flexors and helps avoid falling into crouch. It's a subtle difference, but I think it matters and can help with gait efficiency. Now, this here is a clinical image of a neurologic equinus ankle. Equinus essentially means that the ankle is stuck with the toes pointed down to some degree. This is something that I fairly commonly see. And it's basically related to an imbalance of power between the muscles in the front and back of the calf. Now this girl clearly has drifted such that she's got a very pointed foot and is now stuck here. It's really a non-starter to walk on this. It's very, very difficult to ambulate when your ankle is stuck down like this. And further, it's really non-braceable. And now, many kids won't have as severe of a manifestation as this, but often in neurologic disorders like AFM, a contracture can develop preventing the ankle from getting to 90 degrees. The problem with this is that the braces they're wearing become unwearable because of ulcerations, or the kids just don't want to wear them because they don't fit and they become painful. So I think this can become a problematic deformity, and I do think it needs to be addressed. A braceable foot that gets the heel on the ground is critical to one of our important principles we discussed before of independent mobility. Ankle equinus, or that ballerina type foot we saw on the previous slide, is treatable. And for me, I always try non-operative motive treatment first, like serial casting. This works best in the younger age group, in my opinion, but it's certainly worth trying at any age group. I think it works best in that kind of 4 to 8-year-old age group where the kids are still pretty flexible. And I'll try a series of 3 short leg casts, very similar to what you see here, this green cast in this picture. And we see how much more flexibility we get. Now, if that doesn't work, the next step is surgery. And most often, I'll do what's called an open capsular release, where I release the tight structures behind the ankle, allowing the foot and ankle to sit in a more braceable position closer to 90 degrees. In patients with neurologic issues, a simple Achilles lengthening or just releasing the Achilles tendon will often not get you enough correction. Sometimes the tightness is deeper down on the ankle capsule itself, and this requires a bit more extensive approach to get the correction you want. So again, I'll often do a posterior capsular release of the ankle, followed by casting. And finally, for really severe contractures, like the girl in the last picture, I use what's called a spatial frame to slowly correct the deformity over a period of several months. And so here is that spatial frame. It's this, this contraption you see here. And it's not the norm for an ankle contracture. It's not how I treat every ankle, and it's pretty rare actually, but it is a powerful option. It's quite a bit more involved, and it's my preference to do things as a single stage correction, but very rigid and severe deformity is very helpful. And so what you'll see here on the left is that first presentation, which is very plantar flexed ankle. And then this is about 6 weeks into treatment. You see partial correction, and this is just before we took the frame off with it fully corrected, and the ankle is now at 90 degrees. And, you know, of course, there are variations on the theme here. The ankle doesn't always just go pointed down like that. Sometimes there's a pulling in of the foot, and sometimes you can have the foot pull out or a flat foot deformity. Ultimately, I think it's important that the foot fits in a brace or a shoe. And some differences in the foot are expected when you have a significant neurologic deficit. But as long as the foot is flexible and the brace and shoe is not causing problems, I'll tend to just observe minor foot deformities and work on bracing and therapy. Okay, so next, let's move on to the knees. I think the knees tend to be the second biggest issue I see in paralytic conditions like AFM behind the foot. The reason to focus on the knees is that walking is a complex and coordinated event, and it relies heavily on the quad muscles. If the quad muscle is weak, it becomes very hard to extend the knee. If you cannot extend the knee, it becomes very difficult to walk. Following that, if your knee becomes bent and stuck bent, the gait pattern becomes very inefficient because your quads are working really hard all the time, no matter if you're standing still or walking. So if you remember doing the wall sit from gym class, those were really hard, and they made your legs hurt because your quads were put under tremendous stress as you're sitting in that position. For patients with a crouched gait, they end up in the same situation every time they walk. They can't lock their knees out and let their quads rest, and so as a result, their quads, which are already weak from their neurologic condition, are really burning and hurting as they're basically firing the entire time they are walking or standing. And so this is what a knee flexion contracture looks like. And I'd say that this is at least 30 degrees. And while it's certainly possible to walk with your knees like this, it's very inefficient. It's really not a long-term solution. And I think a lot of kids will end up preferring, even choosing to be mobile via wheelchair if their legs are in this shape. So what can we do about it? Stretching and nighttime splinting are very reasonable first-line options. I think the downside to those options is that they tend to work better for preventing further contracture, but I think it can be hard to gain ground with those techniques. So I think they're important, but the expectation that you'll straighten the knees with just therapy and bracing is difficult. And in my experience, a really aggressive nighttime stretch is poorly tolerated because it's hurting the kids while they're trying to sleep. So what are our surgical options? And what you see here is called an anterior hemiepiphysiodesis. And it's basically a form of guided growth. What these two little screws do is they preferentially close down one side of the growth plate and allow the growth plate in the back of the knee to grow more. And over time, the knee straightens. This is just a cartoon of that. And you see the screw in the front of the knee, near the kneecap, and then the back part of the knee grows such that the limb straightens over time. You get about a degree of month of correction with this technique. And finally, for the more mature kids with crouch who don't have any growth remaining, the shape of the distal femur above the knee can be reshaped with a plate and screws. It's a much bigger operation, big recovery versus those two little screws, which can really almost be a day surgery. So my preference would be to catch this one early and modulate the growth rather than doing this bigger surgery, but this is always an option. So next, let's move on to the hips. So in this image, you can see this paralytic hip dislocation on the left. This right hip is normal and this left hip is out of the socket. This whole area of what to do in terms of treatment of hip subluxation is controversial. I'll tell you, there's just not enough data in AFM to know a clear answer of what to do. So we look at disease conditions that have some similarities, namely spina bifida. So the role of hip status and functional outcomes was looked at in spina bifida. Again, spina bifida is absolutely not AFM, but it is a similar paralytic condition with a wide variety of phenotypes. And they looked at a series of patients with an average age of 31, and they found that neurological level correlated with function. Hip in or out did not affect the outcome, and it did not change quality of life or functional status. And so this group of docs, who's a very experienced group, recommended not putting the hips back in the socket. Again, that doesn't mean that every patient with AFM is not a candidate for hip surgery, but it means just that we have to be careful in our selection of those patients. And this is another study that I thought was interesting because they found that about 20% of spina bifida hips redislocated after surgery, and if you redislocated, you did worse than no treatment at all. Again, it's not AFM. It does help guide me to be somewhat cautious in my selection of patients that will benefit from operative hip reconstruction. So ultimately, I think a lot of thought needs to go into this decision to put a hip back in the socket. The reality is there's not a lot of great data supporting it, and the surgery is very extensive. My concern would always be that a patient could be worse after the surgery because the muscles do take a hit during the recovery, and post-operative stiffness can be significant. So ultimately, to me, this is a case-by-case basis, but I'm just cautious because we just don't know exactly what the right answer is. So let's move on to limb length differences. So limb length differences in neurologic conditions like AFM can be quite common. You can see this boy here is standing on over a 1-inch block to level out his pelvis. Limb length differences tend to arise for two major reasons. One is a unilateral hip dislocation will artificially make the limb shorter because the hip rides up and out of the socket. This is illustrated here as this left hip is much higher than the right, creating the resultant limb length difference, which is B minus A, whatever that distance is. The other way it can manifest is if one leg is significantly more affected than the other, the growth of the more neurologically involved side will be slightly slower. So the first step in treating this is a lift in the shoe or on the outside of the AFO, which is a very simple thing to do. Ultimately, small leg length differences of a centimeter or so are quite common. I don't think they need to be treated. Generally, when we get to 2 to 3 centimeters or an inch, I consider treatment. The simplest way to address this surgically is by slowing down the longer side. This X-ray here is representative, and it's 2 large screws put into small incisions. It's a quick, pretty standard procedure. And basically, you use some graphs and charts to calculate the appropriate time to shut down the growth plate. It's a long side. Usually this is done in the early adolescent years. If you do it too early in childhood, you'll likely overcorrect because it's not really a procedure you can undo. Once you put these screws in, the growth plate is kind of shut down. So to summarize, brace selection is important and the details matter. Promote independent mobility even in a wheelchair. Foot and ankle contracture is common and should be treated. Look out for those bent knees. It's inefficient, but it is treatable. Proceed with caution with hip subluxation, and that each patient is different. And that limb length should be followed through childhood as we have an opportunity to treat the child as the child matures. Thank you very much for your time. This is my email address, and feel free to reach out with any questions at all. It really is a privilege to speak here today, so thanks again. We are now going to transition to the questions and answers portion of the symposium, so please click the sessions button on the right-hand side of your screen to join us for a Q&A session. Thank you.